All right, I have 2 o'clock p.m. We'll go ahead and get started. Hi, everyone. My name is Mohammed Effendi. I'm a neurocritical care pharmacist at Capital Health Regional Medical Center, and I'll be the moderator for today. I'm also joined by neurocritical care pharmacists Megan Kaler and Colleen Barthol, who are going to be help co-moderating in the chat as well as on Twitter. For those that are using Twitter, please be sure to interact with us live and continue discussions on Twitter using the hashtag that you see on the bottom of the screen, NCSPharmJC. It's also on the chat in case you forget it. Just a few housekeeping reminders before we get started. Please be sure to mute yourself when you're coming in the room, as well as during the presentation to avoid any background noise. Additionally, there's going to be 2 presentations today, both back to back, both which are going to be about 30 minutes, including time for questions. After the presenter is complete, you'll have an opportunity to either verbally ask your question if you unmute yourself, or you can also feel free to put your questions down in the chat and I'll read them for you. So let's go ahead and get started. So first, I have the pleasure of introducing Maribel Llamas Rangel, who is a PGY2 critical care pharmacy resident at University Hospitals Cleveland Medical Center. I'm going to stop sharing and hand it over to you, Maribel.
Thank you. Okay. All right. So today I will be discussing the article titled Desmopressin Administration and Impact on Hypertonic Saline Effectiveness in Intracranial Hemorrhage. So just to start off with some background, so intracranial hemorrhage, or ICH, is a subtype of stroke, and it is the second most common cause of stroke, about 15 to 30%. It is considered a medical emergency, and that's because more than 20% of patients will experience a decrease in their glucose coma scale, or their GCS, of greater than or equal to 2 points between their pre-hospital assessment evaluation in the emergency department. So it is required to have early aggressive management due to the high risk of early neurological deterioration, and that is because of the increased intracranial pressure. So the treatment for intracerebral hemorrhage, or ICH, is very similar to how we treat our traumatic brain injuries. So we manage our ICP pressures, or our intracranial pressures. So management is typically broken up into non-pharmacologic therapy or pharmacologic therapy. So our non-pharmacologic therapy includes surgical intervention, head elevation, hyperventilation, therapeutic hypothermia, and our pharmacologic therapy includes our hyperosmotic therapy, which includes hypertonic saline, our HTS, and mannitol. It can also include sedation, analgesia, and chemical paralysis and a barbiturate coma. Based on the Neurocritical Care Society, they do recommend using hypertonic saline, or HTS, management over mannitol. For the purpose of this presentation, we will be focusing on the hypertonic saline or hyperosmotic therapy. So hypertonic saline has been shown to be effective in treating increased intracranial pressure, or ICP, and in cerebral edema due to traumatic brain injury, cerebrovascular accidents. And the way that it works is that an increase in sodium causes an increased gradient shift across the blood-brain barrier, and that draws fluid, that creates a shift in fluid that decreases the intracranial pressure. Some disadvantages is that when you do administer hypertonic saline, a central access is preferred, and it can cause metabolic acidosis and lead to renal injury. You do have it does carry a risk for demyelination, and typically when we're using hypertonic saline in the setting of decreasing ICPs, we typically target a higher sodium levels, typically anywhere from 145 to 155 milliequivalents per liter, depending on the patient, and also tending specific. So there are other risk factors that patients can have for hematoma expansion. So patients have the highest risk for expansion. That includes if the patient is on any oral anticoagulation at home, if they are taking antiplatelet agents, and those that have acquired or congenital coagulation factor deficiencies, if they have inherited or acquired qualitative or quantitative platelet abnormalities. So some modifiable risks that we can actually intervene on in our patients is that they're actually taking oral anticoagulant medications or antiplatelets. Depending on what they are actually taking, they may be reversible. So we can actually offer our patients some sort of agent if they actually have a life-threatening intracranial hemorrhage. So that brings us to desmopressin, or DDAVP. So desmopressin is a synthetic analog of vasopressin, and it works by improving the hemostasis through the release of factor VIII, von Willebrand factor, and tissue plasminogen activator, and it actually increases platelet adhesion. So historically, DDAVP has been used for uremic bleeding, von Willebrand disease, and thrombocytopenia, and some other bleeding disorders. More recently, it has actually, in the 2016 neurocritical care guidelines, due for reversal of antithrombotic and intracranial hemorrhage, started to consider using DDAVP for ICH associated with taking antiplatelets, so that the dose is a lot higher. So it's considered a high dose DDAVP of 0.4 micrograms per kilograms once for over 30 minutes. And this is a lot higher dose than what we would typically be using for diabetes insipidus. So compared to our typical diabetes insipidus dosing is a flat dose of 0.25 to 1 microgram every 12 to 24 hours. If you put this into perspective, a 70 kilo patient would be getting about 28 micrograms. So it's a lot higher dose administered for the reversal of antiplatelets. The duration of action for DDAVP is anywhere from about 6 to 14 hours. So at university hospitals, we actually have adopted the usage of DDAVP for antiplatelet reversal in the setting of intracranial hemorrhages if a patient has a severe intracranial hemorrhage and requires reversal. So DDAVP does have a black box warning for potentially causing severe hyponatremia, and it can actually be used as off-label to prevent overly correcting hyponatremia in patients who come in with chronic hyponatremia. So the way that it works is that it actually binds to the V2 receptor that is located in the collecting ducts, and it actually increases the water reabsorption that causes the hyponatremia. As you can see, this can be problematic in patients who we are trying to decrease their ICPs, because the mainstay therapy for ICH is to commonly achieve those high sodium levels of 145 to 155 to try to prevent cerebral edema. So administration of DDAVP can potentially diminish hypertonic saline effectiveness. So looking at primary literature, there actually has been a lot of primary literature looking at DDAVP for the antiplatelet reversal, but not any primary literature has actually specifically looked at DDAVP in intracranial hemorrhage and the effectiveness that it has on hypertonic saline. There was a study that looked at the use of DDAVP in the setting of traumatic brain injury and on hypertonic saline in patients who used the DDAVP for diabetes insipidus. So in this study, only 14% of the patients, or 15% of the patients actually received DDAVP at a lot lower rate dose of 0.125 to 10 micrograms compared to what we would typically be using it for anti-reversal, which again is the 0.4 micrograms per kilogram dose. But there is very limited data out there using that high dose. So this study did show that DDAVP administration did not cause a significant decrease in sodium and therefore had minimal effects on the actual ICP changes. Again, this was a lot lower dose that was administered, and it was in traumatic brain injury, and it was for diabetes insipidus, so not necessarily for ICH patients. So that brings us to our current journal club. So desmopressin administration and an impact on hypertonic saline effectiveness in intracranial hemorrhage. So this was a retrospective observational chart review, a study. It was single-centered. It was conducted in a level 1 trauma center. And the purpose of this study was to assess the impact of desmopressin on serum sodium levels and hypertonic saline infusion and its effectiveness on ICH. So it was conducted between July 2015 and March 31st, 2020. So patients with hypertonic infusion alone group were matched in a 1-to-1 fashion to patients who received DDAVP plus hypertonic infusion based on age, weight, and sex. So patients in the study were included if they were diagnosed with ICH, received DDAVP for antiplatelet reversal, and had administered 3% hypertonic saline infusion within 12 hours of DDAVP administration. So the reason that they they used 12 hours is because of the duration of DDAVP. It ranges anywhere from 6 hours to 14 hours. So they wanted to make sure that they were assessing within the duration of action of DDAVP. The exclusion criteria included patients that were less than 18 years of age. If they were pregnant, patients were incarcerated, they were excluded. If they were hyponatremic at baseline, which was defined as less than 130 milliequivalents per liter. If they had brain death, that was determined within 24 hours. And then if they received oral or intranasal DDAVP, they were excluded. In terms of their primary outcomes, they looked at patients reaching goal serum sodium within 145 to 155 milliequivalents per liter in patients who received DDAVP compared to those who did not receive DDAVP in intracranial hemorrhage. For secondary outcomes, they look at composite neurological outcomes that included cerebral edema on imaging, worsening hematoma expansion. They looked at midline shift, herniation, any need for unplanned neurosurgical intervention, and neurological decompensation. For their statistical analyses, categorical data was summarized using frequencies and percentages. They used descriptive statistics for continuous variables, and comparative analyses were performed using a t-test and Fisher's exact test. And then the sample size was a convenient sample size. So during the pre-specified time period, there were only 112 patients that were screened. 87 of the patients were actually met exclusion criteria. The majority of the patients that were excluded due to the receiving DDAVP for other indications than reversal. And then 23% of them actually had no hypertonic saline administered. And then 8 patients were excluded because they had hypertonic administered greater than 12 hours after their DDAVP was administered. 6 of them were excluded because they had brain death that was determined within 24 hours. 25 patients were included in the DDAVP plus HTS group, and then 25 patients were then matched to the HTS alone group based off age, weight, and sex. In terms of baseline demographics, so the median age was 65 years of age, and the majority of the patients were male. So 80% of the patient population in this study were male, and the serum sodium at baseline was evenly distributed into both groups. So about average of 38 milliequivalents per liter. The average micrograms for DDAVP administered was 31, and micrograms per kilogram was 0.34 in the DDAVP group. And the hypertonic infusion was 37 milliliters per hour in the DDAVP plus hypertonic saline group, and 43 milliliters per hour infusion for the hypertonic alone group. The hypertonic saline boluses was only 4 administered in the DDAVP plus hypertonic saline alone group, and then only 5 patients actually received hypertonic boluses in the hypertonic alone group. In addition, there were patients in the hypertonic alone group that actually had higher goals. About 70% of them had higher sodium goals in the hypertonic alone group compared to our DDAVP plus hypertonic saline group. So 70% were actually reaching for the 150 to 155 group compared to just 40% in our DDAVP group. So our compared to what we typically do at our institution, the hypertonic dosing seemed to not be as aggressive than what we typically do here. And we at university hospitals, we utilize our hypertonic boluses a lot more frequently than this study actually showed. So I was surprised to see very limited boluses included. So only 4 boluses in the hypertonic saline plus DDAVP group, and only 5 boluses were utilized in the hypertonic alone group. The majority of the patients for type of ICH in both groups was the interparenchymal hemorrhages, and a lot of the patients in both groups actually had concomitant medications affecting sodium, which was actually 0.9%. Sodium chloride was administered in more than 70% of the patients in both groups. So 80% of the patients in the DDAVP plus hypertonic saline group had some sort of additional sodium chloride administered. The study did not break down how much they received and when they received the sodium chloride, which was interesting. And they did mention the anticoagulation usage, which was very similar between both groups. So in terms of the results, the primary outcome reaching the goal sodium within 145 to 155 milliequivalents per liter was achieved in 80% of patients in the DDAVP plus hypertonic saline group and 88% of the patients in the hypertonic alone group. And there was no difference between these, the primary outcome. There were no major differences between the two groups in terms of their secondary outcomes, so time to goal sodium, net change in sodium, ICU hospital length of stay, mortality, or thrombotic events. For the composite secondary outcomes, there were no major differences between the two groups. The need for emergent surgical intervention was higher in the DDAVP plus hypertonic saline group, whether that was the need for EVD or craniotomy. However, this was not statistically significant, but that was 33% in the DDAVP plus hypertonic saline group, and only 10% required emergent surgical intervention in the hypertonic saline alone group. When they when they did the subgroup analyses based off the different sodium goals, so they looked at the differences between 145 sodium to 150 and then 150 to 155. They wanted to see if there was any difference between like reaching the higher goals based off of DDAVP plus hypertonic saline. So there was no difference that was found in the ability to actually reach the goals between when they looked at the 145 to 150. However, it did actually take patients a little bit longer, so 32 hours in the DDAVP plus hypertonic saline group to reach the goal of 145 to 150. And only 18 hours in the hypertonic saline alone group. But again, not statistically significant. But when you have patients like this, that it is a medical emergency, that time difference can be a big difference, and it can lead to clinical difference for these patients. So 32 hours compared to just 18 hours but again, not statistically significant. And looking at the subgroup analyses that looked at 150 to 155 sodium goals. So patients, there was actually a significance when you looked at patients that had the ability to reach the 150 to 155 group. So 82% of them were actually able to reach the goal sodium, 82% in the hypertonic alone group, and only 60% of them were actually able to reach their sodium goal of 150 to 155 in the DDAVP plus hypertonic saline group. Other than that, there was no difference between both groups in time to goal sodium and net change in sodium. So the net serum sodium change over time. I really like this graph because it does show, it breaks down. So the blue line is the HTS alone group, and then the DDAVP plus hypertonic saline is the orange dotted line. So this is the change of sodium over time or over 48 hours. So they assess sodium every 6 hours. So although this was not statistically significant, you can see HTS alone group always had a higher sodium rate compared to the DDAVP plus hypertonic saline group. However, DDAVP plus hypertonic saline group was not too far behind compared to the hypertonic alone group. So author's conclusion is that DDAVP, when used in intracranial hemorrhage, does not appear to negatively impact the ability to reach goal serum of sodiums of 145 to 155 milliequivalents per liter. And in patients that had the higher sodium goals, such as 150 to 155, DDAVP may have decreased the hypertonic saline effectiveness, and further larger randomized studies are needed to assess the relevance of these results on clinical outcomes. So some strains is that this is the only study that has looked at DDAVP administration for antiplatelet associated with ICH and its actual impact on hypertonic saline. So all previous studies that have looked at the DDAVP for the reversal of antiplatelets have only looked at it for antiplatelet reversal and not necessarily looked at its actual impact on how it's used and its effectiveness on hypertonic saline. So hopefully as the usage goes up, more studies are going to start hopefully looking at that impact on ICP and hypertonic saline. But so far this has been the only study, and it actually assessed relevant outcomes. So we looked at neurological decompensation, midline shifts. So looked at a lot of relevant outcomes that we typically look for. And the treatment arms were matched in both groups. So they matched the hypertonic saline group to our DDAVP and hypertonic saline group based off of age, weight, and sex. Some limitations of this study is that the study design, it was a retrospective single center study. With that being said, it was sample size was relatively small, so they screened only 112 patients, and only 25 patients were included in the DDAVP plus hypertonic saline group, and only 25 patients in the hypertonic alone group. So it does limit our generalizability. And there were a lot of trends that we're seeing, such as like the trend that there was a greater trend towards the need for neurological intervention or neurosurgical intervention in the DDAVP plus hypertonic saline group of 33% versus 10%. However, this was not statistically significant, and that could have been because there wasn't a big enough sample size to detect a significance. So there should hopefully bigger studies, maybe there could have been a difference. Their exclusion criteria is another limitation. So it did not exclude patients receiving other fluids in addition to our hypertonic saline. So about 70% of the patients more than 70% of the patients were receiving a concomitant sodium chloride, normal saline in the hypertonic saline group alone. And then in the hypertonic plus DDAVP group, about 80% of them actually received concomitant normal saline on top of what they were already receiving. And they didn't provide the breakdown of how much they were receiving in addition to their hypertonic saline. So it could have affected the sodium goals, but it didn't. The study did not have a breakdown of how much they, in addition to what they were already receiving. So it could have affected our results of this study. In addition, the baseline characteristics did not include the types of antiplatelets that the patients were on at baseline. They did include the anticoagulants that the patient was currently taking at home, but it was interesting to see that there was not a breakdown on what type of antiplatelets that they were currently taking, and only the anticoagulants were included in the study. Other limitations is that the primary endpoint did exclude patients who were only receiving bolus hypertonic saline management. So I know at our institution, we can manage our patients on just bolus hypertonic saline and not necessarily always have to use an infusion. So it does limit our generalizability towards the patients that are just going to be using hypertonic boluses for management. Last is that more patients in the hypertonic saline alone group had higher sodium goals. So 68% compared to 40% of our patients. So you could, those patients might have already started at higher hypertonic saline rates, which there was a slight higher rate in the hypertonic alone group than our DDAVP group. Looking at the baseline characteristics, even though they weren't statistically significant difference. But again, there could have been, those patients could have had a higher rate just because they were already targeting a higher sodium goal. So DDAVP in the setting of ICH associated with antiplatelets do not appear to diminish effectiveness in hypertonic saline in reaching goal serum sodium levels, and should still be used for reversal of antiplatelets. And patients who did have the higher serum sodium goals and received DDAVP may benefit from having from starting a higher hypertonic rate. So overall, in conclusion, DDAVP did not appear to affect the ability for patients to reach sodium goals. That is reassuring to our current recommended practice at our institution. And based off this study, I would not recommend changing our current practice at this time. Further randomized control studies are needed to assess the relevance of these results. And with that being said, I'm happy to answer any questions that you guys may have.
Awesome. Thank you so much, Maribel, for that presentation. It was really good and thorough on a topic of something that I think a lot of people do, desmopressin and DDAVP for ICH secondary to antiplatelets, but all of the data generally doesn't have a lot of data, right? Not a ton of patients. So this still help add to it and give us a little bit more information looking at a very unique question, which was also really good. So if anyone has any questions, feel free to put in the chat or unmute your mic. I'll start off with one question that I had is, you had presented the number of boluses that each group received, and I'm guessing that's how they reported it in just numerical boluses total, but did they report the total volume of boluses? Because of course the total volume of a bolus can vary from being too little to a lot, which maybe it would influence the total amount of sodium the patient's getting. So do you remember if they reported the total volume of boluses? And if not, how do you think that might have affected the results?
Yeah, so that's a good question. Yeah, I looked yesterday and no, they did not report the total volume of the boluses, which I was really surprised. The only thing that I saw in terms of like how much hypertonic saline that they got was just the infusion rates, which was in the baseline characteristic table. Got it.
Thanks for sharing that. Because yeah, sorry, go ahead.
Sorry. I know I was gonna, and then you said, how would that affect?
Oh yeah, your assessment of kind of.
So I think well, I guess it wouldn't necessarily change the primary outcome because those patients were excluded. But I think those patients, actually, that's a good question.
Yeah, and maybe just like thinking about, you alluded to it, how your institution practiced pretty differently than what you study do. And I feel like our institution's also a little bit more maybe bolus happy. And across the board, I'm sure from institution to institution, the practice of which hypertonic to use, which concentration, and then the aggressiveness of boluses versus infusions might vary. And all of that ultimately will have some influence on their serum sodium level. So it's a good point that you brought up, that maybe it would have been more ideal if they had included the total volume. And one more quick question. I think we have time for just one more, and one just came into the chat. Can you please share your thoughts on any biological explanation of why there was a difference between DDAVP plus hypertonics versus hypertonics alone in the subgroup analysis for goal sodium 150 to 155?
So the patients in the 150 to 155 group, those patients were, I think those patients might have already been started at like the higher sodium rates. So that could have been affected, and in like them reaching the sodium of 150 to 155 more, I guess, more likely than the DDAVP plus hypertonic saline group. So I think there's a lot of reasons why those patients might have had a higher chance of reaching those goals to begin with than the DDAVP plus hypertonic saline group.
Awesome. Thank you so much. In the interest of staying on time, there's another question there, but maybe we can take that conversation to Twitter. That's a good question that was posed there. So let me take this time now to introduce our next speaker. Thank you so much, Maribel, again. So our next speaker, we have Abby Hevner, who is a PGY2 critical care pharmacy resident at Novant Health Forsyth Medical Center. And looks like she's got the screen all ready to go. So I'm going to hand it off to you, Abby.
Awesome. Thank you so much for the introduction. Good afternoon, everyone. I'm excited to discuss with you today the results from the CHOICE trial, formerly titled Effect of Intra-Arterial Alteplase versus Placebo following successful thrombectomy on functional outcomes in patients with large vessel occlusion acute ischemic stroke. We'll begin our discussion with a background on acute ischemic stroke. So every 40 seconds, someone in the United States has a stroke, and more than 795,000 people in the US have a stroke per year, 87% of which are acute ischemic strokes. It's estimated that 6 to 8% of patients with acute ischemic stroke are eligible for IV alteplase. And the estimated incidence of large vessel occlusion stroke is 24 per 100,000 patients per year, yet the estimated thrombectomy rate is approximately 3 procedures per 100,000 patients per year. Broadly speaking, patients who present with stroke-like symptoms are transported to the computed tomography suite within 20 minutes, where a CT of the head is performed in order to rule out hemorrhagic stroke while assessing for fibrinolytic eligibility. Once the neurologist assesses the patient for a diagnosis of acute ischemic stroke, the choice to administer tissue plasminogen activator, or TPA, is addressed, and CT angiography may be performed depending upon the neurologist's opinion if they deem the patient a candidate for mechanical thrombectomy. So endovascular thrombectomy is the preferred treatment modality in patients with large vessel occlusion. And the 2019 AHA-ASA ischemic stroke guidelines recommend mechanical thrombectomy within 6 hours in patients with a functional pre-stroke baseline, middle cerebral artery occlusion, age 18 years and older, an NIH or National Institutes of Health stroke scale score of 6 or greater, and an Alberta Stroke Program early CT score or aspect score of 6 or greater. And these recommendations were a result of multiple randomized controlled trials published in 2015. The Alberta Stroke Program early CT score or aspect score is just a 10-point quantitative score used to assess early ischemic changes on a non-contrast head CT. A score of 10 is normal, and then less than or equal to 7 correlates with negative functional outcomes. And again, patients are typically eligible for thrombectomy with a score of 6 or greater. And I'll note here that the eligibility criteria regarding time from last known well was extended after the publication of the DAWN and DEFUSE 3 trials, as you can see here. Once thrombectomy is performed, reperfusion success is evaluated utilizing digital subtraction angiography and treatment in cerebral ischemia or TICI scoring. The modified TICI score used prior to the development of the expanded TICI score or eTICI grades reperfusion, with grade 0 indicating no perfusion and grade 3 as complete or full reperfusion in all distal branches. The expanded or eTICI score, an extension of the mTICI score, grades reperfusion from 0 to 3, with 3 indicating full reperfusion. And recent data have been published suggesting that eTICI allows for more accurate predictions of outcomes relative to mTICI. And then ultimately, successful reperfusion after thrombectomy is defined as an mTICI greater than or equal to 2B/3 or an eTICI greater than or equal to 2B50. Rates of reperfusion based upon TICI scoring are high at 71%, and this is with regarding mechanical thrombectomy with or without intravenous alteplase. However, these high rates of reperfusion do not necessarily correlate with high rates of positive clinical outcomes. Currently, a documented 27% of patients are disability-free at 90 days post-intervention, which identifies a possible gap in care. And it's hypothesized that the use of intra-arterial fibrinolytics may assist in closing that gap. The thought process behind this considers 2 possible mechanisms. Perhaps there was irreversible ischemic damage prior to reperfusion, or there are persistent thrombi within the capillaries which remain unseen on DSA. If it is the latter, then perhaps localized fibrinolytic therapy may assist in dissolving these residual thrombi after thrombectomy and improve functional outcomes, which is the theory behind the trial that we are discussing today. And that brings us to our discussion on the CHOICE trial published in the Journal of the American Medical Association in February of 2022. The purpose of this trial was to assess the preliminary efficacy and safety of adjunct intra-arterial alteplase treatment compared with placebo in patients with large vessel occlusion acute ischemic stroke treated with thrombectomy that resulted in successful reperfusion on digital subtraction angiography, emphasizing that this trial was performed in patients who were considered as having a successful thrombectomy, not in patients who would need a rescue agent, so successful thrombectomy. This was a multi-center phase 2B randomized double-blind placebo-controlled trial, which compared intra-arterial alteplase to placebo administered after successful thrombectomy with or without intravenous alteplase. And the study was conducted in Catalonia, Spain from December of 2018 to May 2021. An independent data and safety monitoring board and clinical research organization conducted all study monitoring, and patients were screened at 7 different comprehensive stroke centers, all of which had uninterrupted access to performance of thrombectomy. And the decision to perform thrombectomy followed any local treatment guidelines, specifically the European Stroke Organization guidelines, which coincide with the AHA/ASA guidelines. And the required aspect score was at least 6, and imaging modalities were selected based upon last known well. Inclusion criteria are here and are as follows: age of 18 years and older, modified Rankin of 0 to 1, at baseline, so functional at baseline, symptomatic large vessel occlusion in the anterior, middle, or posterior cerebral artery, patients treated with thrombectomy within 24 hours after last known well, and a post-thrombectomy eTICI score of 2B50 or greater. Exclusion criteria are listed here as well and included patients with contraindications to the use of intravenous alteplase per any local and national guidelines, except for time to therapy. Patients were also excluded if they had an NIH stroke scale greater than 25, complete clinical recovery in the angiography suite, use of a carotid artery stent that would require dual antiplatelet therapy during the first 24 hours after treatment, pregnant or lactating females, current participant in another study, or unlikely to be available for 90-day follow-up. Patients were randomized in the angiography suite using a 1-to-1 ratio between active treatment with intraarterial alteplase and placebo, and they were stratified by center and use of intravenous TPA before thrombectomy, and block randomization was performed as well. Intraarterial alteplase was dosed at 0.225 milligrams per kilogram with a max dose of 22.5 milligrams, and the placebo was prepared and looked identical to alteplase. The infusion time was originally 30 minutes, however, it was adjusted to 15 minutes during the trial due to the COVID-19 pandemic and a need to limit exposure to patients. And it was injected into the lenticular striate territory. The goal was to avoid proximity to the thrombus and focus on the microvasculature to decrease any potential risk of bleeding. The dose of alteplase was derived from the IMS-3 trial, where patients who received alteplase for acute ischemic stroke or intravenous alteplase were then randomized to receive additional endovascular therapy or IV TPA alone. So intraarterial TPA could be used in that study, and the dose in that trial was 22 milligrams. Regarding the use of IV alteplase, investigators decided duration of infusion, and patients were classified as having received alteplase if at least half of the weight adjusted dose was administered. Thrombectomy was performed according to usual practice, and any devices under study were not included, and a maximum of 6 passes were allowed for inclusion into the trial. Additional protocol items are listed here. Intraarterial alteplase or placebo was stopped if contrast extravasation was present during the infusion. IV heparin, as well as other anticoagulants and dual antiplatelet therapy, were prohibited during the first 24 hours, and blood pressure and blood glucose goals are listed here as well. The primary efficacy outcome was the proportion of patients with a modified Rankin score of 0 or 1 at 90 days, functionally independent at 90 days. Secondary efficacy outcomes included improved angiographic findings, a shift analysis of modified Rankin score at day 90, an MRS of 0 to 2 at day 90, infarct expansion ratio, proportion of those with an expansion ratio greater than 1, and infarction at 24 to 48 hours after stroke onset. Tertiary efficacy outcomes included a Barthel score, ischemic worsening, and quality of life questionnaire, and these were all methods of assessing quality of life and functional status. All adverse effects were recorded as well, and the primary adverse events compared were symptomatic intracerebral hemorrhage defined as neurological deterioration and a 4-point increase on their NIH stroke scale within 24 hours after treatment, plus evidence on imaging, and then death at 90 days was compared. Clinical assessments were performed at baseline, 24 and 48 hours after randomization, 5 to 7 days after randomization, and at 90 days. All imaging was reviewed in a blinded manner. The study investigators calculated a probable sample size of 100 patients per treatment group to provide 80% power to detect a difference in the primary outcome. And this assumed a treatment response rate up to 40% in the control group and a 21% absolute benefit in the intervention group for a 0.05 two-sided type 1 error, and no study losses were accounted for due to a planned treated as randomized analysis. Listed here are the statistical analyses that were performed. For the primary outcome, an adjusted risk difference was estimated using binomial regression, and post-hoc sensitivity analyses were performed to consider any imbalances in baseline characteristics, as well as differences based upon study site and the use of intravenous alteplase. Other statistical methods are below and were appropriate. Patients were analyzed based upon a treated as randomized. No adjustments were made for multiple analyses, and adjustments were made to odds ratios and risk differences based upon previous alteplase use. There's no missing data imputation, and the level of significance was defined as a p-value less than or equal to 0.05. After reviewing the methods, we will move into the results. The trial was prematurely discontinued due to slow enrollment and inability to maintain placebo availability, with 60% of the calculated sample size having been enrolled. Of note, an independent clinical events committee adjudicated safety outcomes and serious adverse events. From December 2018 to May 2021, 1,825 patients with acute ischemic stroke were treated with thrombectomy at the 7 study sites. 121 patients were randomized into the trial, which includes approximately 7% of the total patients treated with thrombectomy at the 7 sites. 802 patients were excluded due to an ETICI score of 3 when the protocol initially required 2B50. 113 patients received their randomized treatment, and 8 patients were not included in the treated as randomized population due to early reocclusion of the treated vessel, peri-procedural complications, and a COVID-19 infection diagnosed immediately after randomization. Additional reasons for exclusion are listed here, highlighting that 215 patients had contraindications to alteplase. And lastly, treatments received after randomization are listed here in this chart, with alteplase on the left and placebo on the right. And this ultimately ended with 61 patients included in the primary analysis for alteplase and 52 in the placebo group. Overall, patients had a median age of 73 years, were greater than 90% white, and 46% were female. Baseline characteristics are listed here, and these patients had moderate severity strokes with near normal aspect score, and 62 and 60% received IV alteplase in the experiment and control groups, respectively. Continuing with our baseline characteristics, we have the documented locations of occlusion. Mostly middle cerebral artery occlusions were observed in this trial. Next pertains to workflow times. Notably, patients in the alteplase group reached randomization and start of study treatment approximately 40 minutes faster than the placebo group. And lastly, a comparison between the groups regarding ETICI scores at randomization are here. So patients in the placebo group had higher rates of poorer reperfusion at randomization compared to those in the alteplase group, or appeared to have higher rates. Now, regarding the results of the primary outcome, 59% of patients in the alteplase group met the primary endpoint of an MRS of 0 or 1 at 90 days, compared to 40.4% in the placebo group. And this result was statistically significant with an adjusted absolute risk difference of 18.4%, which is the numbers needed to treat of 6 patients. And note that the 95% confidence interval is wide, suggesting a lack of precision. There were no statistically significant differences reported regarding these secondary outcomes which pertain to imaging-related findings, though this trial was not powered to do so. And data presented using median as a measure of central tendency in these cases denote data which may not be normally distributed. I also note the interquartile ranges were wide, as well as the 95% confidence intervals. This table shows the differences between groups of the modified Rankin scale score at 90 days, and the chart here provides a visual to address the distribution of scores between groups, with lighter shades indicating lower disability. Tertiary outcomes were not significantly different among the groups. Again, this trial was not powered to detect such differences. And regarding adverse effects, 0 patients were reported as having ICH in the alteplase group compared to 2 in the placebo group, or 3.8% of those patients. Death was numerically lower in the alteplase group compared to the placebo group, as well as any other documented serious safety events. With the methodology and results in mind, we'll now transition to the conclusions and discussion. The authors concluded that the use of intra-arterial alteplase resulted in greater incidence of excellent neurological outcome at 90 days compared with placebo after successful thrombectomy in large vessel occlusion acute ischemic stroke. And this trial supports safety of intra-arterial alteplase after successful thrombectomy at 0.225 milligrams per kilogram with a max dose of 22.5 milligrams over 15 to 30 minutes. They noted that enrollment was impacted by the COVID-19 pandemic, and early termination may lead to overestimated treatment effects. These are preliminary findings which should require replication, and improved functional outcomes may be explained by improving the microcirculatory perfusion, going back to our original statements in the background. Now for the discussion. The strengths of this trial include strong methodology. It was randomized, double-blind, placebo-controlled. They utilized block randomization and stratification. There were low rates of adverse events in the treatment arm, and post-hoc sensitivity analyses were performed to adjust for any potential confounders due to differences in the baseline characteristics. The limitations of this trial include a low sample size and lack of diversity within the population. Wide confidence intervals, as stated before, limit precision of the results. There were no adjustments made for multiple analyses, which increases risk for type 1 error. So in other words, a finding reported as significant when it in fact is not. The ability to terminate alteplase early may confound the results. And there was a potentially clinically meaningful difference in time to randomization and treatment between the groups in favor of alteplase. Also noted here that patients on anticoagulation would have been excluded due to IV-TPA exclusion. The bottom line is that this trial reports preliminary findings that suggest a possible benefit regarding 90-day functional outcomes in patients receiving intra-arterial alteplase after a successful thrombectomy in large vessel occlusion acute ischemic stroke, as well as positive preliminary safety outcomes. And larger randomized controlled trials should be conducted to confirmed findings. Of course, the question is always, should this change clinical practice? And my answer is that this trial gives us promising and exciting data and information. However, I would want this to be replicated with the goal to enroll more patients to confirm the findings and ensure both efficacy and safety. Future and ongoing studies or trials. So there was some discussion. One of the lead investigators was interviewed by a group of neurointerventionalists, and there was some discussion around a choice 2 trial, which ultimately the hope would be to reproduce the results with a higher sample size, and they would continue to use alteplase in that case. So if they're able to conduct a second trial where they can reproduce these results with a larger number of patients, then they hope to do so. And he also mentioned a possible publication in the pipeline addressing the advanced imaging data from the CHOICE trial. So he mentioned some exciting information regarding MRI perfusion and MRI spectroscopy that may confirm the theory that this is a problem within the microcirculation and not just that there's irreversible damage prior to thrombectomy that results in these poor clinical outcomes or functional outcomes at 90 days. So thank you for your time and attention, and I'm happy to answer any questions or take comments at this time.
Abby, thank you so much for the presentation. Very thorough and very interesting topic with a very interesting concept behind it of targeting the microcirculation. So very interesting. It'll be interesting to see where this kind of goes from here. I'm sure we'll all be hearing more about this. So we have a question in the chat from Christy Olmos. Can you please comment on high patient exclusion rate? Is it clinically feasible to recommend this treatment when 1,800 patients were scanned and only 50 were included in the trial?
Yeah, great point. So there were more than 50 included in the trial. I think there were like 62 in one arm and 50 in the other. But yeah, there was an extremely high exclusion rate, partially due to, in the original protocol, they were only including patients with 2B50 flow. And the idea behind that, based upon the comments of the lead investigator, was they were originally hesitant to perform this in patients with TICI-3 flow because they said they have TICI-3 flow, everything looks great, and I'm more concerned about causing an ICH in a patient who already has great reflow. And so then after some discussion, I think they changed that to allow for TICI-3 flow patients to be included in the trial. So over 800 patients were originally excluded for that. And then there was a reasonable number that is similar to other trials for exclusion. So I think they were somewhat disappointed by the end that they weren't allowed, to include all those patients because they had to change the protocol. But ultimately, yes, I would agree that we need a much larger study to confirm these findings in both the efficacy and the safety areas.
Great, thanks for that background. We have another question in the chat. Would patients with poor TICI outcomes 0 to 2A also benefit from intra-arterial alteplase?
Great question. Yeah. So most of the data that we have with intra-arterial alteplase is actually as a rescue agent in this 0 to 2A population. So the patient undergoes mechanical thrombectomy. They may have gotten intravenous alteplase, and then the interventionalist decides to, ultimately use intra-arterial fibrinolytic as a rescue agent. And there's been some benefit shown or possible benefit shown. Most of the data that I've seen have been retrospective. So I don't think that we could say that based upon the results of this trial, because this trial was, successful thrombectomy or higher TICI flow, but, a randomized trial to support that would be great. And there's certainly retrospective data out there that you could use.
Great, thanks. A few more questions. Did the authors comment on why there was higher spontaneous intracranial hemorrhage at 24 hours in the placebo arm versus the intra-arterial alteplase arm?
Great question. I do not recall their commenting on that in the paper or in that video. So I don't recall them commenting on that. But I can look back at the paper and double check and shoot you an email and let you know.
Great. Another good question, asking, do you use the same dosing at your institution for intra-arterial alteplase? And then they say that we use 8 to 10 milligrams at their institution.
Yeah, great question. So at my institution, from what I understand, we don't necessarily use intra-arterial alteplase. And if we do, it's based on the clinical discretion of the neurointerventionalist. So that's currently my understanding of our practice. But I plan on hopefully discussing this with some of the interventionalists at my facility.
Yeah, we also have, honestly, a variety of dosing at our institution. We don't do it commonly, of course, but we do have different neurointerventionalists that have a few different dosing ranges that they would use, but it doesn't come up too often. Another question or comment here says, hard to understand a rationale for weight-based intra-arterial dosing, which isn't commonly done for other intra-arterial meds. That's actually a really good point I didn't even think about. What are your thoughts on that?
Yeah, it's a really great point. And again, this video of the lead investigator, his comments were so helpful because he really, elaborated on the dosing choice. And in the study protocol, it's a bit more scientific in how they chose it, or they attempted to be a bit more scientific. But ultimately, if you think about it, it's almost like a fourth of the weight-based systemic dose. And so I think it was really just this idea of, hey, let's try this. And I don't know necessarily if there were, tons of scientific thought, or if it was just maybe a safety barrier that caused them to say, well, in a smaller patient, maybe we'll give them less than a higher dose, a higher standardized dose. Yeah,
good point. I have one question. Every time I see alteplase, I can't help but think about tenecteplase these days. So do you think in this type of way the alteplase was used intra-arterially after a thrombectomy, is there you think plausibility of maybe tenecteplase being researched in this fashion?
Yes. So that was actually a question I anticipated with tenecteplase sort of becoming the favored one. Certainly, possibly a reasonable, method of conducting a trial, and maybe they do one where you have a facility that's using tenecteplase now instead of alteplase, and then you also give tenecteplase, intraarterially as well. I don't know, how you would conduct those types of trials necessarily, and tenecteplase is more fibrin specific. So would there be a greater concern for safety? Would it be more efficacious? I'm not sure, but definitely something that would be interesting to evaluate.
For sure. And dosing too would be, there's intraarterial dosing for tenecteplase, but not in this fashion. So, if anyone did want to do this, what you're describing in this study, I don't know what the dose reference would even be for tenecteplase. Has this come up to your knowledge at your institution of anyone wanting to do this?
Not yet. So I anticipate it coming up, but not yet.
Yeah, and we're all probably in a similar boat. Keep those very wide confidence intervals handy when they come to you, because I like that you highlighted the point that
That's right.
we're very wide confidence intervals. Okay,
Yeah,
great.
it's great fun data and promising, but we definitely have to be critical and good statisticians when we review this data and apply it to our patients.
Indeed, well said. All right, so that was all the questions. I want to thank everyone so much for joining us today, and to both of our presenters, Maribel and Abby. Please be sure to continue this conversation on Twitter by continuing to use the hashtag NCS PharmJC. Thanks again to everyone. Hope everyone has a great day.